step back into the grim, grimy, and often brutal world of Victorian medicine. It's the 19th century. You tie your apron tight, brace yourself, and prepare to face the horrors doctors encounter every day. No antibiotics, no sanitation protocols, no reliable anesthesia, just you, a handful of tools, and an endless tide of suffering. This is a week in the life of a Victorian doctor, and why, if you were unlucky enough to live back then, you'd be lucky to survive even that long in such a merciless profession. If you think becoming a doctor today is tough, imagine the path in Victorian England. Medical training was inconsistent, often dangerously inadequate, and there was no universal standard. Many entered practice scarcely ready for the grim realities awaiting them. In the early 19th century, aspiring physicians followed a patchwork of routes. Instead of today's long years of university study and rigorous clinical rotations, many learned their trade through apprenticeships. If you had money or connections, you might attend a medical school in London, Edinburgh, or Glasgow, though even these lacked the breadth and scientific rigour expected today. An apprenticeship meant shadowing an experienced doctor for several years, starting as an observer before taking on more responsibility. Some mentors were skilled and generous with their teaching. Others saw apprentices mainly as unpaid assistants. Much of your learning came from outdated textbooks riddled with superstition, misconceptions, and dangerous errors. One of the most unsettling parts of training was anatomy. Dissection was essential for understanding the human body, but legal cadavers, mostly from executed criminals, were scarce. This shortage fed the grim trade of resurrectionists, who stole fresh corpses from cemeteries for medical schools. You might find yourself in a dissection room where the air was thick with decay, or if unlucky, standing in a graveyard at night, waiting for body snatchers to deliver their grim cargo. Surgical instruction was just as jarring. With anesthesia rare or absent, operations were fast, messy, and agonizing for the patient. You'd watch limbs sawed off while the person screamed and thrashed, the surgeon working at breakneck speed to finish before shock or blood loss claimed the victim. Pharmacology offered little comfort. Treatments ranged from herbal remedies to toxic substances like mercury. Bloodletting and purging remained popular despite their dangers. Without the scientific method fully embedded in medicine, much of your work was guesswork, often fatal guesswork. Even with the Medical Act of 1858 introducing the General Medical Council to regulate qualifications, many practitioners still operated with dubious credentials. Medicine was costly to learn, so poorer students often had no choice but to accept minimal training and hope to pick up skills on the job. By the end of your education, you carried theory in your head, but little real experience. The rest you'd learn through trial, error, and grim necessity, often at the expense of your patients. And with that shaky foundation, you stepped into practice, unprepared for the chaos ahead. Waking as a Victorian doctor meant relying on instruments that were as dangerous as the illnesses you faced. Germ theory wasn't yet accepted, sterilization was almost unheard of, and your surgical kit could spread disease as easily as treat it. Inside your leather bag, you'd carry scalpels, bone saws, forceps, and lancets for bloodletting, plus the occasional jar of leeches. Instruments were reused between patients without cleaning. A scalpel fresh from an infected wound might go straight into the flesh of another. Wards reeked of blood and rot, and hygiene was barely an afterthought. Joseph Lister's antiseptic methods, introduced in the 1860s, were groundbreaking but slow to catch on. Until they did, gangrene and sepsis claimed more lives than the original injuries. Surgery was brutal. Ether and chloroform had appeared by the mid-19th century, but they were risky too much, and the patient might never wake. Too little, and they'd be fully conscious. Many operations were still done with nothing but a rag to bite on. Bleeding was hard to control, transfusions were experimental and dangerous, and without knowledge of blood types, they were often killed rather than saved. Diagnostics were rudimentary. The stethoscope, invented in 1816, was revolutionary yet limited. Thermometers and blood pressure devices were rare. Lab tests were almost non-existent. Much of your treatment was based on symptoms, not causes. On house calls, you'd navigate filthy alleys or overcrowded tenements, ready to deliver babies, stitch wounds, or amputate limbs in dim, unsanitary rooms. Your hands and face were unprotected from blood or pus, leaving you constantly exposed to typhoid, tuberculosis, and other deadly infections. Every time you picked up a tool, you were gambling with a life, sometimes the patient's, sometimes your own. In an age where knowledge and equipment were equally imperfect, the stakes could not have been higher. Much of your work as a Victorian doctor wouldn't take place in neat clinics or hospitals. It happened in cramped, filthy homes. House calls were the backbone of your practice. Leather bag in hand, you'd travel by foot, horse-drawn carriage, or omnibus through streets thick with smoke, sewage, and despair. Cities were booming but bursting at the seams. Working-class families packed into tiny, damp rooms with almost no ventilation. Overflowing cesspits, heaps of garbage, and sewage-tainted water created perfect breeding grounds for disease. Your wealthier patients lived in comfortable houses, but most of your time was spent in overcrowded tenements where dozens shared the same building. Dark alleys led you past rats, stray dogs, and the sharp tang of decay. Indoors, coal smoke clouded the air, and sick rooms were stifling. Beds sagged under feverish bodies, often surrounded by relatives too sick or too exhausted to help. The air was heavy with the smell of infected wounds, rotting tissue, and tuberculosis coughs. Gaining entry wasn't always easy. Some feared doctors, worried about high fees or harmful treatments. Others begged for your help. With no clean surfaces or sterile tools, you examined patients wherever you could, kneeling on floors, leaning over kitchen tables, dodging children and livestock. Each visit carried risk. Without gloves or masks, you were exposed to every cough, drop of blood, and smear of mucus. Typhus, cholera, and scarlet fever could claim you as easily as your patients. Travel itself was exhausting, whether wading through rain-soaked streets or braving freezing nights. In poorer districts, theft or assault was a real threat. Communication could be another hurdle. Immigrant communities or rural families often relied on folk healers, mistrusting official medicine. Persuading them to follow your advice was a constant uphill battle. House calls also confronted you with poverty's rawest face. Starving children, mothers worn out by endless pregnancies, fathers maimed in factories. You became part doctor, part social worker, arranging charity help or pleading for better sanitation. But often, your efforts failed. Disease and deprivation claimed patients despite everything you did. Every knock on a door might open onto a scene of suffering you'd never forget. To last even a week, you needed not just skill, but stamina, compassion, and a stomach for human misery at its worst. In Victorian England, survival meant knowing your enemies, and they were legion. Infectious diseases thrived in overcrowded cities, striking without warning and with devastating results. Tuberculosis, consumption, was the era's great killer, slowly draining life from the lungs while spreading easily through coughs. Entire households wasted away while you could offer only rest, fresh air, and food luxuries most couldn't afford. Cholera struck like lightning, spread through contaminated water. It could kill within hours from dehydration. John Snow's 1854 Broad Street pump discovery began to reveal the waterborne link, but in the meantime, you stood powerless against its speed. Typhoid fever arrived through tainted food or water, bringing high fever, abdominal pain, and deadly intestinal perforations. Like cholera, treatment was little more than comfort care. Smallpox still caused regular epidemics despite Edward Jenner's vaccine. Many rejected inoculation and isolation measures were crude at best. The disease disfigured or killed without mercy. Scarlet fever and measles swept through children's wards and poor neighborhoods. You saw tiny bodies racked with fever and rashes, knowing complications could still kill weeks later. Syphilis carried both stigma and suffering, destroying bodies and minds over years. The mercury-based treatments you had were as toxic as the disease itself. Childbirth remained one of the most dangerous experiences a woman could face. Puerperal fever, hemorrhage, and obstructed labor claimed countless mothers and infants. Respiratory diseases like pneumonia and bronchitis flourished in smoke-choked, damp conditions. With no antibiotics, all you could do was keep the patient warm and hopeful. Industrial injuries brought mangled limbs, burns, and fractures. Surgery could save them, but often at a terrible price. Against these enemies, your tools were meager. No antibiotics, scarce vaccines, and only basic pain relief. Many battles were lost before they began, and the emotional toll was as lethal as the illnesses themselves. For centuries, doctors believed draining blood could cure disease. As a Victorian physician, you were expected to wield lancets and leeches with confidence, even when the results were disastrous. The theory dated to Hippocrates and Galen. Illness came from an imbalance of the body's four humours, and blood was the easiest to reduce. You might open a vein with a blade, apply leeches to draw it out, or make large incisions for rapid loss. In reality, the treatment often hastened death. Weak patients collapsed, and repeated sessions left them too frail to recover. Infections spread easily from unsterilized instruments, and hemorrhage was a constant risk. Yet tradition and patient expectation kept bloodletting alive long after its harm became clear. It wasn't just for fevers or infections. Mental illness, headaches, and even pregnancy complications were treated this way. By the time germ theory gained ground, the practice had already claimed countless victims. Performing it became a moral weight. You followed your training and your patient's wishes, all the while suspecting you were doing more harm than good. Victorian surgery was a race against time, infection, and the patient's endurance. The operating room, if it could be called, that was often a dim, unheated space with stained floors and reused tools. Amputations were among the most frequent operations. Industrial accidents, battlefield wounds, and rampant gangrene left no other option. Speed was everything. Even with ether or chloroform, when they were used, patients sometimes woke mid-procedure, screaming in pain. Survival hinged on avoiding shock and post-operative infection, both of which were common killers. Older, more archaic operations lingered. Trepanning, drilling into the skull, was still used for head injuries, seizures, or mental disturbances. The pain was excruciating, and death or disability was almost inevitable. Routine but dangerous procedures filled your days. Lancing abscesses, setting broken bones, removing cataracts, delivering babies with forceps. Each carried high risks of infection, deformity, or death. Caesarean sections were last resort measures, and mothers rarely survived. Anesthesia brought relief, but also danger. Misjudging the dose could kill. Infection remained the ever-present enemy, with instruments uncleaned and doctors working in everyday clothes. Every operation was a gamble. You worked knowing that even flawless technique could end in tragedy. The physical strain was great, but the psychological cost of repeated loss was greater. For a Victorian doctor, hospitals were paradoxical places. On one hand, they offered opportunities for more extensive care than house calls. On the other, they were often grim, overcrowded, and rife with disease. Stepping into a Victorian hospital meant confronting some of the era's darkest medical realities. Hospitals had come a long way since the medieval era, but in the 1800s, Many still resembled warehouses for the poor and sick. They were overcrowded, with rows of beds packed close together and minimal sanitation. Patients suffered from infections, malnutrition, and neglect as much as from their original illnesses. The public viewed hospitals with suspicion and fear. Many associated them with death rather than healing. Families often avoided sending loved ones to hospitals unless absolutely necessary, fearing infection or mistreatment. For doctors, hospitals were both workplaces and battlegrounds. The lack of proper hygiene was a constant source of frustration. Surgeons and nurses rarely washed their hands between patients. Instruments were reused without sterilization. This negligence led to rampant spread of infections like puerperal fever, a devastating postpartum infection that claimed many mothers. Hospital staff worked long hours under harsh conditions. Nurses were often poorly trained and overworked, and doctors faced intense pressure to treat numerous patients with limited resources. Despite these challenges, hospitals also became centers of medical innovation. Figures like Joseph Lister pushed antiseptic methods here, slowly transforming surgical outcomes. You might find yourself caught between old practices and new scientific ideas, trying to balance hope with harsh reality. In some, Victorian hospitals embodied the struggle of medicine itself, a place of both progress and peril, where survival was never guaranteed. The mid to late Victorian era marked a turning point in medicine with the gradual acceptance of germ theory. But as a doctor in those years, you'd be caught in a turbulent transition between old beliefs and new science. For centuries, the dominant medical paradigm was the miasma theory, the idea that diseases were caused by bad air or poisonous vapors. This meant doctors focused on odors, cleanliness as smell control, and environmental factors, but not the microscopic agents actually causing illness. In the 1850 seconds and 60 seconds, pioneers like Louis Pasteur and Robert Koch began demonstrating that tiny organisms, bacteria, and viruses were responsible for infections. This discovery promised to revolutionize treatment, but the medical community was slow to accept it. Joseph Lister was among the first to apply germ theory to surgery. In the 1860 seconds, he introduced antiseptic techniques using carbolic acid to sterilize wounds and instruments. His methods drastically reduced infections and mortality rates in surgical wards. However, many doctors resisted these ideas. Sterilizing tools was time-consuming and costly. Some colleagues dismissed germ theory as radical or unproven, clinging to traditional practices like bloodletting and miasma explanations. As a practicing Victorian doctor, you might have faced ridicule or isolation for adopting antiseptic methods, or you might have continued with older, riskier techniques, constrained by habit, resources, or skepticism. The slow acceptance of germ theory meant that for much of your career, infection control was haphazard at best. You'd witness patients die from post-surgical infections, not understanding how to prevent them fully. The struggle between old and new medicine defined Victorian healthcare. It was a time of hope, conflict, and gradual progress, but also a period when many lives were lost due to ignorance and resistance to change. Among the many tragic realities Victorian doctors faced, few were as heart-wrenching and relentless as puerperal fever. Also known as childbed fever, this infection struck women shortly after childbirth, often with fatal results. For doctors attending births in the 19th century, puerperal fever was a devastating spectre one that claimed thousands of mothers and tested the limits of Victorian medicine. Puerperal fever was a bacterial infection, primarily caused by Streptococcus bacteria, which invaded the uterus and bloodstream after childbirth. Symptoms usually appeared within a few days post-delivery and included high fever, chills, abdominal pain, foul-smelling vaginal discharge, and severe weakness. Without effective treatment, the infection could rapidly progress to septicemia, blood poisoning, and death. In the crowded, unsanitary conditions of Victorian England, puerperal fever was terrifyingly common, especially in urban hospitals and poor homes. Estimates suggest it accounted for up to 15% of maternal deaths during the period, with mortality rates soaring as high as 30–40% in some hospitals. Doctors and midwives were the primary attendants at births, but their understanding of puerperal fever was limited. They often unknowingly transmitted the infection from one patient to another via contaminated hands, instruments, or clothing. At the time, the germ theory of disease was not widely accepted, and many doctors did not practice hand washing or sterilization. One of the most infamous cases that exposed the medical community's role in spreading puerperal fever was that of Dr. Ignaz Semmelweis, a Hungarian physician who worked in the Vienna General Hospital in the 1842. Semmelweis observed that women delivered by doctors had a much higher rate of puerperal fever compared to those attended by midwives. He hypothesized that doctors were transferring cadaverous particles from autopsies to birthing rooms. When he instituted a policy requiring hand washing with chlorinated lime solution, mortality rates plummeted. Sadly, Semmelweis's ideas were ridiculed and ignored by many of his contemporaries. It would take decades before antiseptic techniques became widely accepted, and in the meantime, thousands of women continued to die. As a Victorian doctor, childbirth was one of the most challenging and emotionally draining aspects of your practice. You often dealt with desperate, frightened women in cramped, poorly ventilated homes or overcrowded hospital wards. Deliveries were performed with minimal analgesia. Ether or chloroform were used occasionally but not universally. Often, you had only your bare hands and simple tools, such as forceps, to assist with difficult births. You were acutely aware that many women would not survive the ordeal. Beyond puerperal fever, complications like hemorrhage, obstructed labor, and preeclampsia were common killers. But puerperal fever, fueled by lack of hygiene, was especially ruthless. You might have had to deliver several babies in a single day, each time risking carrying infection from one patient to the next. Gloves were rarely worn, hand washing was not routine. Surgical instruments were reused without sterilization. Clothes and linens were infrequently cleaned or changed. Before germ theory's acceptance, prevention of puerperal fever was virtually impossible. Many doctors tried a range of treatments: bloodletting, purgatives, mercury compounds, and herbal remedies. None were effective and often worsened the patient's condition. When antiseptic principles were finally introduced, mainly by Joseph Lister, in the 1860s, they began to change outcomes slowly. Sterilizing instruments, hand washing, and clean dressings reduced infection rates. However, in poor urban areas, overcrowded hospitals and lack of resources made widespread adoption difficult. Many women still gave birth in unsafe conditions, and midwives and doctors resisted new protocols for years. Witnessing puerperal fever's devastation was emotionally crushing. Mothers died, while their infants survived or perished as well, leaving families shattered. Doctors felt helpless and haunted by their inability to save lives. Some physicians suffered from profound guilt, especially once Semmelweis's and Lister's discoveries were known. The knowledge that they might have contributed to deaths through negligence weighed heavily. Yet, Victorian doctors operated under enormous social and economic pressures. Medical education was inconsistent, hospitals were underfunded, and understanding of infection was primitive. The system itself often sets them up to fail. For a Victorian doctor, surviving even a week in practice meant facing diseases like puerperal fever that you could neither predict nor cure effectively. The combination of limited knowledge, unsanitary conditions, and high patient loads created a perfect storm. Your hands' primary tools of healing became vectors for deadly infection. Without rigorous hygiene protocols, you risked spreading puerperal fever from patient to patient. Your patients were often too poor to seek hospital care, leading to dangerous home births. When hospitals were used, they were overcrowded and poorly equipped. In the end, puerperal fever was a cruel reminder that Victorian medicine was still in its infancy. Doctors had the will to help but lacked the means. Surviving a week as a Victorian doctor was not only about battling diseases or mastering brutal treatments, it was about enduring the relentless, exhausting grind of a workload that left little room for rest, reflection, or recovery. The demands on doctors were immense, and the physical and mental toll was crushing. Unlike today's hospital-centered care, much of Victorian medicine happened through house calls. Doctors travelled by foot, horse, or carriage across cities and countryside to attend patients in their homes. These visits were often long, physically demanding, and performed in all weather conditions, rain, snow, or sweltering heat. Each call meant carrying a heavy bag of instruments and medicines, navigating muddy streets, poorly lit alleys, and sometimes dangerous neighborhoods. Your patients were spread far and wide, often making it impossible to see everyone promptly. Doctors frequently worked from dawn until late at night, sometimes making multiple visits in a single evening. Emergencies did not wait. A woman in labor, a child with high fever, a factory accident victim could require immediate attention at any hour. The Victorian population was booming, especially in urban centres like London, Manchester, and Birmingham. Overcrowding, poverty, and poor sanitation meant disease spread rapidly, increasing demand for medical care. Doctors often had hundreds of patients to oversee. For those working in poor areas or as general practitioners, the sheer volume of cases was staggering. You might see dozens of patients a day, many with serious illnesses requiring close attention. This overload left little time for detailed diagnosis or follow-up. Quick judgments, often based on limited information, became the norm, a recipe for mistakes. Despite the heavy workload, many Victorian doctors were poorly paid, especially those serving working-class communities. Many patients couldn't afford regular fees, paying only when they had money, or bartering services. Doctors without wealthy patrons or private practices struggled financially. They had to balance their desire to help with the need to keep their practices afloat. Financial insecurity added stress and sometimes forced doctors to take on more patients than was safe or manageable. The relentless pace and constant exposure to suffering, death, and despair took a severe emotional toll. You faced grieving families, angry patients, and the pressure of responsibility for life and death decisions. Depression, burnout, and feelings of helplessness were common among Victorian doctors, but rarely discussed openly. Many turned to alcohol or other coping mechanisms to manage stress, risking their health and careers. Victorian doctors often worked in relative isolation. Unlike today's team-based approach, doctors frequently lacked collaboration with nurses, specialists, or mental health professionals. Medical knowledge was evolving rapidly, and keeping up with new discoveries required time and resources you often didn't have. Additionally, the medical profession was highly competitive and hierarchical. Young doctors struggled to establish themselves, while older doctors resisted changes threatening their authority. The demanding work schedule also strained personal lives. Victorian doctors were often on call day and night, leaving little time for family or rest. Their long absences could strain marriages and relationships. Children grew up with absent fathers, and wives bore the burden of household management alone. The sheer intensity of the Victorian doctor's workload made survival beyond a week extraordinarily challenging. You faced a brutal combination of physical exhaustion, financial insecurity, emotional stress, and professional isolation. Even the most skilled and dedicated doctors risked breaking under the pressure. Mistakes were inevitable, and consequences could be fatal for patients and sometimes for the doctors themselves. Surviving this relentless grind required resilience, determination, and a bit of luck. It was a daily battle on multiple fronts against disease, ignorance, poverty, and your own human limits. Before you could even face the horrors of Victorian medical practice, you had to survive the grueling, often inadequate process of becoming a doctor. Medical education in Victorian England was a brutal rite of passage, marked by long hours, insufficient training, and exposure to terrifying realities that would shape your entire career. Whereas today's medical schools are highly structured, Victorian medical education varied widely depending on where you studied and who you apprenticed with. Many aspiring doctors began by apprenticing under an established physician, a process that could last several years. This meant learning through observation and hands-on experience, often without formal lectures or examinations. Medical schools existed, but were not standardized. Some were prestigious institutions, like the University of Edinburgh or London's Royal College of Surgeons, while others were less reputable diploma mills. Access to top schools was limited by social class, wealth, and connections. For many, medical training was prohibitively expensive, and students might have to work odd jobs or rely on family support. The curriculum was heavily focused on anatomy, physiology, and rudimentary pathology, but often lacked comprehensive instruction in hygiene, pharmacology, or emerging scientific methods. You spent hours dissecting cadavers, which were notoriously hard to come by legally. Many bodies came from grave robbers or resurrectionists, who supplied medical schools with corpses stolen from fresh graves, a gruesome and illegal trade. This dissection work was physically and psychologically taxing. Students had to confront death in its most raw form, often under poor ventilation and with the stench of decay. The experience left many traumatized or desensitized. The scarcity of bodies led to infamous incidents like the Burke and Hare murders in Edinburgh, where people were killed to sell their bodies to anatomists. Such scandals brought public outrage and legal reforms, but the supply remained precarious. As a student, you risked legal trouble if caught possessing an illegal corpse. However, dissection was considered essential for understanding human anatomy and crucial to becoming a competent doctor. Clinical training was limited and often haphazard. Students might spend time in hospitals, observing or assisting senior doctors, but hands-on practice was rare before qualification. Hospitals themselves were overcrowded and unsanitary, exposing students to infections and harsh conditions without adequate protection. Passing examinations to obtain a medical license was difficult. You had to demonstrate knowledge of anatomy, surgery, medicine, and sometimes chemistry. The process was highly competitive and often influenced by social standing or patronage rather than merit alone. Failure meant restarting training or abandoning your ambitions entirely. Throughout your education, exposure to death and disease was constant. From dissecting bodies to witnessing surgical operations without anesthesia, the experience was both terrifying and formative. The brutal reality of disease in Victorian England became clear early on, preparing you for the grim tasks ahead. Despite the rigorous training, much of what you learned was based on outdated or incorrect medical theories. The dominance of humoral theory, the reliance on bloodletting, and the dismissal of germ theory meant your education was sometimes more harmful than helpful. You were taught to treat symptoms with harsh methods rather than cure diseases, setting the stage for difficult decisions later in practice. The intensity and darkness of Victorian medical education affected students deeply. Many struggled with fear, anxiety, and desensitization to suffering. Some became cynical or cold, while others were overwhelmed by the weight of responsibility they would soon bear. Your medical education in Victorian England was a trial by fire. It was a period of physical hardship, mental strain, and exposure to the raw realities of human mortality. The training prepared you in some ways, but left you ill-equipped to face the brutal conditions of actual medical practice. The gulf between education and the realities of 19th century medicine was wide and dangerous. In Victorian England, being a doctor was a complicated social position, one filled with contradictions, pressures, and unexpected stigma. While you might imagine doctors enjoyed prestige and respect, the reality was often far more nuanced and difficult. Doctors occupied a middle ground in the rigid Victorian class hierarchy. Unlike aristocrats or wealthy businessmen, doctors were professionals who earned respect for their knowledge, but were rarely considered part of the upper class, unless they amassed significant wealth or social connections. Many doctors struggled to assert their status, especially those serving working-class neighborhoods or rural areas. Their education and skills separated them from their patients, but their financial means often did not. This ambiguity led to a constant negotiation of identity. Were you a learned gentleman, a humble servant to the poor, or simply a tradesman? Many patients, especially in poorer communities, viewed doctors with mistrust or fear. Medical knowledge was mysterious and sometimes frightening, and doctors were often associated with pain, death, or unpleasant treatments. Some believed doctors intentionally caused harm or profited from illness. Rumors and superstitions about quackery or malpractice were common. This distrust could lead to non-compliance with treatments, hostility during consultations, or refusal of care altogether. When treating working-class patients, you often encountered harsh living conditions, poverty, overcrowding, malnutrition that limited the effectiveness of medical interventions. Patient skepticism and fatalism made your work harder. You might face verbal abuse or threats, especially when your advice conflicted with local beliefs or traditions. Your efforts to improve hygiene or sanitation were frequently ignored or impossible to implement due to economic realities. Within the medical community, competition was fierce. Professional societies and licensing bodies held power, and disputes over medical knowledge or status were common. Doctors often jealously guarded their practices and reputations, and younger practitioners struggled to break into established circles. Rivalries between surgeons, physicians, and apothecaries further complicated professional life. The vast majority of Victorian doctors were men, as the profession was closed to women until late in the century. Male doctors faced social pressure to maintain a certain demeanor, stoic, authoritative, and unemotional. Showing doubt or weakness could damage your reputation. Women doctors, when they finally entered the field, encountered intense prejudice and exclusion. The social demands on doctors extended into their personal lives. Marriage prospects were influenced by profession, income, and social connections. Doctors' long hours and stress often strained family relationships, and their social circles could be limited by the demands of practice. Victorian newspapers and literature often portrayed doctors in mixed lights, sometimes as heroes battling disease, other times as inept or callous figures. Medical scandals, malpractice cases, and public health failures shaped popular opinion. Given these challenges, many doctors experienced social isolation or loneliness. Their position made it difficult to fully relate to either wealthy elites or impoverished patients. Some found solace in professional clubs, religious groups, or social reform movements. Being a Victorian doctor meant navigating complex social terrain. You were respected yet distrusted, educated yet isolated, responsible yet vulnerable. This social stigma added another layer of difficulty to an already brutal profession, making survival, both professional and personal, even harder. One of the most frustrating and dangerous aspects of being a Victorian doctor was the limited arsenal of effective medicines at your disposal. Medical treatments were often based on flawed theories and unproven remedies, which meant that your efforts to cure or ease suffering frequently resulted in harm or, at best, no improvement. Much of Victorian medicine was rooted in the ancient theory of the four humours: blood, phlegm, black bile, and yellow bile, believed to govern health. Disease was thought to result from an imbalance of these humours, so treatments focused on restoring balance. Bloodletting, purging, and the use of emetics to induce vomiting were common practices aimed at cleansing the body. Such interventions were not only ineffective but often weakened already ill patients. Arguably the most infamous treatment of the era, bloodletting was applied for everything from fever to inflammation. Using leeches or lancets, doctors would drain blood in the hope of releasing bad humours. The practice was dangerous, sometimes causing severe anemia, shock, or death. Yet it remained popular well into the 19th century, largely because it was ingrained in medical teaching. Mercury compounds were prescribed for various ailments, including syphilis and skin conditions. These treatments caused severe side effects like mouth ulcers, neurological damage, and poisoning. Other toxic substances such as arsenic, antimony, and opium were also used, often without proper dosing or understanding of their effects. Purging was intended to rid the body of impurities through diarrhea or vomiting. Common purgatives included senna and rhubarb, while emetics like ipecac were administered to induce vomiting. These treatments frequently dehydrated and exhausted patients without addressing underlying diseases. The Victorian era saw a boom in patent medicines over-the-counter remedies, marketed with extravagant claims but little regulation. Many contained alcohol, opium, or other addictive substances. As a doctor, you had to compete with these quacks, who sometimes gained more trust than trained physicians. Crucially, Victorian medicine lacked antibiotics. Bacterial infections, from simple wounds to deadly diseases like tuberculosis and pneumonia, could not be effectively treated. Anesthetics like ether and chloroform were introduced mid-century but were not universally available or safe. Many surgeries were performed with patients fully conscious, adding to trauma. Surgery was fraught with danger. Without sterile techniques, the risk of infection was enormous. Mortality rates were high, and patients often died from sepsis or shock. Amputations and other invasive procedures were performed quickly and crudely, reflecting the urgency and limited tools at hand. Knowing that your treatments could harm patients was devastating. Many doctors struggled with guilt when cures failed or when interventions worsened conditions. You faced a constant tension between the desire to help and the reality of ineffective or harmful medicine. Despite these challenges, Victorian medicine was a period of gradual advancement. The introduction of antiseptics, the slow acceptance of germ theory, and improvements in surgical techniques laid the groundwork for future progress. Still, during much of the era, effective medicine remained out of reach for most patients. As a Victorian doctor, the tools and knowledge at your disposal were often insufficient or dangerous. You operated in an environment where well-intentioned treatments frequently failed or caused new problems. This lack of effective medicine made your role harrowing and your chances of success slim, adding yet another obstacle to surviving even a single week in practice. One of the most brutal realities of Victorian medical practice was the constant presence of epidemics. Cholera, typhoid, tuberculosis, and other infectious diseases ravaged cities and countryside alike, overwhelming doctors and communities. Surviving even a week as a Victorian doctor meant facing the terrifying front lines of these relentless crises. Cholera was one of the most feared diseases of the 19th century. It struck rapidly and fatally, causing severe dehydration and death, often within hours. Victorian doctors were ill-equipped to combat cholera effectively. The true cause, contaminated water, was only slowly accepted after John Snow's groundbreaking work in the 1,850 seconds, and public sanitation was woefully inadequate. Treatment was mostly symptomatic and often ineffective. Attempts to balance humours or used toxic substances did little to save patients. Cholera outbreaks led to mass panic, quarantine measures, and overwhelmed hospitals. Doctors worked long shifts under appalling conditions, exposed to the disease themselves. Typhoid fever, caused by Salmonella typhi bacteria, was endemic in Victorian cities with poor sanitation. Its symptoms, high fever, abdominal pain, delirium, made it hard to diagnose and treat. Like cholera, typhoid was spread by contaminated water or food, a fact that took decades to be widely accepted. Doctors faced constant waves of typhoid patients, many of whom succumbed to the illness or complications such as intestinal rupture. Tuberculosis, TB, often called consumption, was a slow, wasting disease that killed hundreds of thousands during the Victorian era. Highly contagious and incurable at the time, TB thrived in overcrowded, poorly ventilated homes and workplaces. Doctors struggled to provide comfort rather than cure. Many themselves contracted TB, given their close contact with patients. Hospitals were often filled beyond capacity during epidemics. Sanitation was poor, and cross-infection was common. Doctors and nurses worked tirelessly, often with insufficient supplies, protective gear, or knowledge of disease transmission. The emotional strain of watching so many patients die was immense. The repeated devastation caused by epidemics eventually spurred public health reforms. Sanitation acts, clean water initiatives, and quarantine laws were introduced. However, these measures were slow to implement and met resistance from landlords, businesses, and politicians. Doctors often found themselves advocating for public health while continuing to fight infections on the ground. Treating epidemic diseases carried a high personal risk. Many doctors caught diseases themselves and died young. Despite this, most remained dedicated, driven by a sense of duty and compassion, even when success seemed impossible. Facing epidemics was the ultimate test of a Victorian doctor's endurance and skill. The relentless waves of disease, the fear, and the human suffering pushed doctors to their limits daily. Surviving a week, let alone a career, under these conditions was a monumental challenge, making clear why many doctors did not last long in the profession. Imagine the dawn breaking over the grimy streets of Victorian London. The fog hangs thick like a shroud, muffling the clatter of horse-drawn carts and the distant cries of street vendors. You, an exhausted, overworked doctor, are already on your feet. Before the sun fully rises, your day begins, and it will stretch long into the night. A relentless march through sickness, suffering, and despair. There is no gentle awakening, no peaceful morning ritual. Your body aches from yesterday's endless rounds, your clothes still damp from rain and sweat. A quick meal of stale bread and weak tea is all you have time for before you grab your leather satchel, filled with jars, scalpels, bandages, and the heavy weight of expectation. Outside, the air is cold and damp, the streets slick with muck and refuse. As you step out, the sharp tang of smoke from factory chimneys mixes with the stench of sewage, a smell that will cling to your clothes and hair no matter how many times you wash. Your first call is a desperate one, a young woman in labour, her screams echoing through the narrow, suffocating rooms of a cramped tenement. You push past a crowd of anxious relatives, your hands trembling slightly as you prepare for the delivery. There is no clean room, no sterile instruments, just a filthy mattress and the stale air thick with fear. The mother's face is pale, sweat beading on her brow, and her cries pierce your heart. You work quickly, your hands steady, despite the chaos. The baby arrives, crying weakly. Relief floods the room, but your work is far from over. You clean the mother as best you can with water that is hardly pure, dress the wound with cloth strips, and prepare for the inevitable postnatal infections that could claim her life. No sooner have you left when a frantic messenger arrives, a worker, injured in a nearby factory explosion. You rush through twisting alleys, the sounds of the city growing louder and more urgent. At the factory, the scene is gruesome. Blood stains the rough wooden floor, and the injured man's screams mix with the crackle of fires and the shouts of panicked workers. You kneel beside him, your fingers probing a jagged gash deep into his arm. With trembling hands, you must decide whether to attempt saving the limb or perform a quick amputation. The tools are crude, a saw with a dull blade, no anesthesia. The man's agonized cries cut into your soul, but the risks of infection and gangrene leave no choice. You work quickly, your heart pounding. The blood loss is terrifying, but there is no time for second thoughts. You bandage the stump as best as you can and promise the man you'll return, though you know the odds are grim. As dusk falls, your bag grows heavier with the toll of the day. Your clothes cling to you, soaked with sweat and grime. You move from patient to patient, visiting the fevered child coughing in a dark attic, the elderly woman wasting away with tuberculosis, the drunken man delirious with alcohol poisoning. Each door you open reveals another story of suffering. Families crowded into squalid rooms, the children pale and listless, the stench of illness thick in the air. You do what you can, offer rudimentary remedies, comfort, and sometimes just a reassuring word. But your efforts often feel futile. Death shadows every household. Your failures haunt you, lingering like ghosts after you leave. Back at your modest lodgings, long after the gas lamps have flickered to life in the streets, you sit at a wobbly desk. You write feverishly case notes, prescriptions, bills until your eyes blur and your hand cramps. Sleep is a distant dream. You are haunted by images of pain and loss, by the sound of cries and silence alike. Tomorrow will be no easier. This was the daily reality for a Victorian doctor, a brutal, exhausting, often heartbreaking struggle to save lives with limited knowledge and tools in a world rife with poverty and disease. Surviving one day was a battle. Surviving a week was a testament to sheer grit, and surviving a career required almost superhuman resilience. The Victorian doctor's day is filled with suffering and death, but it doesn't end when the patient's doors close behind him. The emotional burden presses down relentlessly, wearing away the doctor's spirit in a world with little support or understanding for mental health. To survive the profession, you had to wrestle with your own mind as much as with disease. From the moment you donned your coat, you carried not just a bag of instruments, but a crushing responsibility. Every decision, every action could mean the difference between life and death. Yet you often faced this burden with incomplete knowledge, inadequate tools, and the despair of watching patients slip away. When a mother begged you to save her child, or a father pleaded for relief from agonizing pain, the pressure was suffocating. You had to appear confident and calm, even when doubt gnawed at your core. Victorian society regarded mental illness with fear and shame, especially among men and professionals. Doctors were expected to be paragons of strength and reason. Admitting to anxiety, depression, or breakdowns could mean ruin for a career already precariously balanced. As a result, many doctors hid their emotional struggles. They bore their pain in silence, without access to counseling or support groups. Long nights haunted by patient suffering left you vulnerable to insomnia and exhaustion. Rest was often impossible, as you replayed failures and agonized over missed diagnoses. Anxiety attacks, palpitations, trembling, nausea became common, but were hidden behind a mask of professionalism. Some doctors turned to alcohol or opiates to dull the pain, unknowingly stepping into dangerous addictions. Tragically, the relentless strain sometimes led to mental collapse. Some doctors suffered psychotic breaks or severe depression, forced to leave the profession or be confined to asylums. In an era when psychiatry was rudimentary and often cruel, these breakdowns were stigmatized and misunderstood. Few colleagues offered compassion or aid. Victorian medical treatments frequently harmed patients. The knowledge that your intervention could worsen suffering was a source of profound guilt. Many doctors agonized over the harm caused by bloodletting, amputations, or toxic medicines. This moral weight compounded the physical exhaustion. To survive, doctors developed coping strategies. Some turned to religious faith, finding solace in prayer or belief in divine purpose. Others used gallows humor, a dark, cynical wit that allowed them to face horror without being consumed by it. Close friendships with fellow doctors, when available, offered rare moments of empathy and understanding. Many Victorian doctors died young, worn down not just by physical disease, but by emotional exhaustion. Some lived isolated, haunted lives, their sacrifices invisible to a society that demanded miracles without offering support. While patients' illnesses were visible and tangible, the internal battle doctors fought was hidden. The emotional toll of Victorian medical practice was enormous, and it claimed as many victims as the diseases themselves. Understanding this burden is essential to grasping why surviving even a single week as a Victorian doctor was such a monumental feat. The final hours of a Victorian doctor's day were often the hardest. After hours spent battling filth, disease, and despair, when the gas lamps flickered on and the city settled into uneasy quiet, you found yourself alone with your thoughts exhausted, drained, and haunted by the day's toll. Walking back through the dark, fog-shrouded streets, the weight of the satchel on your shoulder was matched only by the weight on your mind. The night air was cold and sharp, but your body burned with fatigue. The once lively city now seemed silent, except for the occasional coughing from a shadowed alleyway or the distant howl of a stray dog. Your footsteps echoed as you passed shuttered shops and empty taverns. The journey home was never truly peaceful. Your mind replayed the day's scenes, the mother lost in childbirth, the factory workers' desperate cries, the children coughing in the cold. You asked yourself, did I do enough? Could I have done better? Physical exhaustion was immediate and brutal. Your muscles ached, your vision blurred, and your hands trembled. Yet rest was often fleeting, stolen between worry, record-keeping, and preparing for the next day. Sleep, when it came, was troubled and haunted by nightmares, visions of failed patients, blood-stained hands, and faces etched with pain. In those quiet hours, self-doubt gnawed relentlessly. The limits of your knowledge and skill were glaring. You knew many patients would not survive despite your best efforts. You wondered if medicine was truly a healing art or a cruel game of chance. Could the failures be blamed on your skill, the tools, or the society that allowed such suffering? Despite the fatigue and despair, you had to carry on. Each morning demanded the same bravery, the same willingness to confront suffering anew. There was no room for weakness. Patients, families, and society looked to doctors as pillars of hope. Survival as a Victorian doctor was fragile. One infection caught in a patient's home, one misstep during surgery, one overwhelming outbreak could end your life and career. Many doctors succumbed to disease, stress, or breakdowns early in their careers. Those who endured often did so through sheer stubbornness or faith. Even amidst the chaos, moments of profound human connection and compassion offered solace. A grateful smile, a fragile life saved, or a child's recovery reminded you why you endured. These rare glimpses of success sustained many doctors through the darkest days. As you finally closed your eyes, the day's struggle was far from over. The unseen battles against exhaustion, doubt, and despair were as fierce as any disease. This was the ultimate test of the Victorian doctor's survival, not just to heal bodies, but to endure the endless emotional and physical warfare the profession demanded. And so, as we step away from the dim gas lamps and foggy streets of Victorian England, we can begin to understand just how brutal the life of a doctor truly was. Faced with primitive tools, limited knowledge, and overwhelming disease, these men and women fought battles on multiple fronts against sickness, against despair, and even against their own bodies and minds. Surviving a week, a month, or even a year as a Victorian doctor was no small feat. It took resilience, grit, and an unwavering commitment to care in a world that often seemed indifferent to suffering. The sacrifices they made laid the groundwork for the advances in medicine we often take for granted today. Thank you for joining me on this journey through history's shadows, a glimpse into a time when the white coat was stained with more than just blood and ink. If you found this exploration as eye-opening as I did, please consider liking, subscribing, and sharing. It helps keep this channel alive and lets us dive deeper into stories that deserve to be remembered. Until next time, stay curious, stay compassionate, and never forget the human stories behind every scar and every cure.